So that's the diffuse large B-cell lymphoma and still Hodgkin. So Hodgkin lymphoma. What is classical over here? It's a CD20 negative, okay? But it's CD15 and CD30 positive, okay? And typically the hallmark is a Reed-Sternberg cell. We know it's a B cell through sequencing, but still it's not a B lymphoma. We don't take it in the VHO classification, so it's special. And it's special with prognosis because, the prognosis is better because typically we see the lymph node on the neck very early, so we can only radiate. We don't have to do chemotherapy. And in this case, the patients survive pretty well. In contrast to non-Hodgkin's lymphoma, which you discover later, in later stages of the disease. Although the Ann Arbor classification is the same for both of them, okay? You can use the brentuximab as the drug to help in combination with the chemotherapy. With a Reed-Sternberg cell, of course, you know that it's a special cell. It has typically more nuclei, 2 nuclei, or even more, and 2 nucleoli. So 2 nuclei, it has 2 nuclei, 2 nuclei. It looks like an oval eyes. So that's a characteristic cell. And you have 4 types. So there's a lymphocyte-rich variant, okay? Then there is a nodular sclerosis. That's the most common, like 70%. There's a fibrosis of the lymph nodes, so they're fibrotic, very hard. Lymphocyte-rich has the best prognosis. Then lymphocyte depleted, so no lymphocyte depleted, has the worst prognosis, and then you have a mixed version. And this is a special one. The Reed-Sternberg cells, they attract everything, but also there's interleukin 5, so typically it's combined with eosinophilia, and that's a pretty common question in tests. So remember, if you have lymphadenopathy, lots of eosinophils, it could be Hodgkin's disease, okay? So that's Hodgkin's disease over here. And that's the last one I want you to remember from the germinal center neoplasms. And let's get to the last one. So those are the post-germinal center neoplasms. Okay, they should be in a way like in the maturation process at the end, and post-germinal center neoplasms. And the first one over here is the marginal zone lymphoma. Okay, so this is marginal zone lymphoma. And as the term says, well, it starts in the marginal zone, and typically there are 3 interpreters you should know, and that's Hashimoto's thyroiditis. So it's connected with these 3 inflammations or problems. So Hashimoto's thyroiditis, Sjögren's syndrome, and Helicobacter pylori. So if you have a chronic inflammation of this type, then you can develop a marginal zone lymphoma. And typically with these 2, you can call it also MALToma, because these 2 have mucous membranes, not the thyroid. So they have a mucous membrane, so it's MALToma, okay? A cool thing about, for example, the Helicobacter pylori and then MALToma of the stomach is that if you get rid of Helicobacter and you stop the inflammation, it can regress, okay? That's one of the examples. That's marginal zone. And then we have the important one, which is chronic lymphocytic leukemia / small lymphocytic lymphoma. Yeah, so it has 2 versions. One of them is liquid, that's CLL, and one of them is rather solid, and that's SLL if you have lots of lymphadenopathy, okay? Again, CD20 positive, of course. And so it's a B-cell non-Hodgkin's lymphoma. And what is important over here, tests ask about smudge cells. Smudge cells are like deformed, bursted cells. When you put it on blood smear, they break. They're very fragile, the lymphocytes. So remember smudge cells. And typically it lasts very long, 10 to 12 years or even more. It's a chronic leukemia, lymphoma. And typically it has 5 stages. Stage 0 is like only increased lymphocytes. So you check the leukocytosis, but then 1, 2, 3, 4. Basically, the more years you have it, then you swap the stages. So in stage 1, you got some lymphadenopathy. In stage 2, you got splenomegaly. And then you start to have problems because you're going to have anemia. And at the end, you're going to have thrombocytopenia, so you can bleed. And this is also connected with problems with immunity because you have a clone of a lymphocyte. So basically, the other gamma globulins are not working, so you're having hypogammaglobulinemia. That's right. So infections, and they can die on infection. And also, in case they're producing some immunoglobulins, they can cause autoimmunity. So you have typically autoimmune hemolytic anemia, and you can have also immune thrombocytopenia. Okay. So that's what the test asks. So remember, hypogammaglobulinemia infection, smudge cells, autoimmune hemolytic anemia, and immune thrombocytopenia. That's crucial. Okay, so they're bruising at the end. Then another example, and again, it's the DLBCL. Okay, so remember over here you got DLBCL, so diffuse large B cell lymphoma, and this one is the one connected with HIV typically, so HIV induced. And also it could be a transformation from the CLL. Okay, so from CLL can transform, so it's a complication. And in both of these cases, it's rather post-germinal center lymphoma. So de novo, thanks to new appearance of DLBCL through HIV, or it could be transformation from CLL. Okay, so remember that. And then we're heading to one which is special because this one is rather really liquid. It's rather only leukemia, chronic leukemia. So CLL is a chronic leukemia, and this one you take as a chronic, another example of chronic leukemia. It has no lymphadenopathy, or it's very rare to have a lymphadenopathy in this case, and it's called hairy cell leukemia. So again, CD20 positive. Yep. And it's chronic, 10 years survival. But what is crucial, no lymphadenopathy. And also if you do a puncture of the bone, it's dry, so there are not too many cells in the bone marrow. So bone marrow there are no cells, decreased cells. But there's splenomegaly typically. And what is special is that you will find these cells, the hairy cells, the leukocytes, you will find in red pulp. Remember that, not a white pulp. That's where you would expect them to be, but it's in red pulp. Okay, yeah. And another thing, very important, it's a TRAP positive. So for TRAP Spain, tautorate resistant acid phosphatase, it's positive. So typically, and these cells, they have like hairs. It's a cytoplasm which like looks hairy. So that's why you call it hairy cell leukemia, which you see these lymphocytes in the blood. Another important hallmark over here is a treatment which is by 2-CDA. 2-CDA is an analog of adenosine, of purine. So, and it's a 2-chlorodeoxyadenosine. And this is an analog of the purine, and it blocks adenosine deaminase. So it's a adenosine deaminase inhibitor. And typically the neoplastic cells, if you give to patient 2-CDA, this will accumulate in the neoplastic cells and works as a toxic agent and kills the cell. So it really helps the treatment, okay? That was hairy cell leukemia, typically no lymphadenopathy over here. And we're getting to another one where it's no lymphadenopathy, and it's our beloved multiple myeloma. So, thanks for watching. And don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.